The kidneys are an essential part of our body, and they are really an overlooked organ. We're constantly thinking about the brain, the lungs, the heart, the most essential organs, but the kidneys are actually responsible for so many things. And because of that, there are a lot of meds, there are a lot of labs, all kinds of things to be looking at as a nurse. And sometimes we wonder, or I have students ask me, well, what is the most important? So I've thought of a list of things that you should know, every nurse should know about the kidneys, including the labs. So number one, you should always know what your potassium level is, because the kidneys are largely responsible for getting rid of our potassium, and we know that if our potassium is too high, that will cause cardiac arrest. So you should always know what your potassium is, okay? You also need to know what your creatinine is. Creatinine tells us about kidney damage. So if your patient is going for some sort of CAT scan or cath lab test where they're going to receive dye, you always need to be thinking about the kidneys, because dye is going to be processed through the kidneys, and if the kidneys are already damaged or compromised, then they're not going to be able to handle the dye, and you could put someone in renal failure. And if they go into renal failure, their potassium could get too high and they can go into cardiac arrest and die. So very important that you know the creatinine, okay? And it should be less than 1. And the potassium, depending on what book you're looking at, 3.5 to 5 is our range for potassium. Now, some people can handle a much higher potassium than others, but this is the general guideline that you should be looking at. Okay, so always know your creatinine and your potassium, if nothing else. Something else that you should be looking at, of course, is your I&O. Kidneys are responsible for fluid balance, and we always want to be about 500 mLs plus or minus on our I&O. So you always want to think about how much is going in, how much is coming out. And if we're fluid overloaded, then perhaps we need some medication to help dump that fluid. Maybe the kidneys are compromised, which we would know by looking at their creatinine. Okay, so always be looking at your I&O. When your patient is in the hospital, we always need to be thinking about, like I said, exams that they're going to have. So whenever you have a patient who's going for CT scan, you always want to ask yourself, is it with or without contrast? If it's with contrast, then you want to check and see, well, then what is my creatinine? Now, radiology should be also looking at what is the creatinine. But if they forget or think about you're the last line of defense, then it's your responsibility to also look at the creatinine. Now, let's say a patient's had an MI. They really have to have a cath test. Okay, they need to go to the cath lab and find out what kind of damage are we having. Or is it something we can fix? Well, let's say their creatinine is high. There is a way to protect the kidneys if the benefit of the test outweighs the risk of renal failure, okay? So number one, we can pre-medicate. So if your patient has a CT scan or a cath lab test with contrast ordered, and whenever they go to cath lab, assume they're going to get dye, okay? You're going to call the doc and say, hey doc, the creatinine is elevated. Would you like to pre-medicate with something? Generally, they're going to pre-medicate with Mucomist. Mucomist is a really funny drug because Mucomist is, if you look it up in the drug book, for Tylenol overdose. But it is also for decreasing mucus, thinning mucus when someone has really bad congestion, and it's also to protect the kidneys. So you have to think about, if they're on Mucomist, why are they on it? Okay, so Mucomist in this case would be for pre-treating the kidneys to help protect them. Then after the test, you're going to want to flush the kidneys. So you're going to anticipate IV fluids, some sort of isotonic like a normal saline, maybe a liter bag flush. If they're not on IVs, then you want them to drink water. Okay? So you're always thinking about, okay, they've just had their exam, what method are we going to use to flush out their kidneys? It's either going to be IV fluids or drinking a lot of fluids. Then you want to watch the I&O, and the urine should pick up. And we also want to look at the color and the clarity of the urine. So the urine should be kind of a nice pale yellow color, and it should be clear. Okay, if you remember, if they have a Foley catheter, don't assess the urine in the bag, because the more urine you have in the bag, the darker it will look. You want to look at the actual tubing and see what does it look like in the tubing. That's a more accurate assessment of what your urine looks like. Okay. Something else to think about. So let's say your patient is a renal patient, meaning they are either pre-dialysis, or so they're in acute renal failure, or they're a chronic renal failure, meaning they're on dialysis. Okay. Then you want to look at, so for dialysis, you have to look at what is their access. Do they have a permanent graft or fistula, in which case you have to assess the thrill and the bruit. It's generally in the arm, and so you're going to look for kind of a big lumpy area on the arm. Ask the patient, where is your dialysis access? Okay. If they have that, then 3 times a week they should be having the dialysis nurse come in. They put needles into that site every single time that they dialyze. Or is it more of an emergency or short term, or did they just discover they needed dialysis? Then they would have maybe a VASCath or a permacath, which permacath would be up in the chest. VASCath could be here or in the groin area. And you'll know that it's a dialysis access instead of a central line, because it generally has 2 ports, sometimes 3, but it's wrapped in gauze. And that's how you'll know that that is the dialysis access. You do not use that for IV fluids or any blood draws, anything, without express permission from the renal physician. Okay, because that is the patient's lifeline. And if you clot that line, they could die. Okay, so patient with dialysis, one of your priorities is, just like it's right up there with, do they have a pulse, are they breathing? Is their access patent? So do they have a thrill and bruit? Okay. So what kind of access do they have? Very important priority when you have a dialysis patient. And what kind of meds are they on? So dialysis patients are generally on something to decrease their phosphorus, some sort of phosphate binder. They can't get rid of their phosphorus well, so we have to help them along. And they also should be on a diet with not very much phosphorus, and they should also be on a diet lower in potassium. They are always anemic. So patients who are on dialysis, remember the kidneys are responsible for producing erythropoietin. The liver does help a little, but the kidneys produce that, and that helps us make red blood cells. So renal patients are almost always in the 8.0 area of hemoglobin, and so we do not transfuse blood unless they're symptomatic. So they're always anemic. Okay, so they're usually on some sort of iron, or they get Epigen after dialysis. So you might see an order for Epigen, and it's usually done on dialysis days. They usually get it only on those dialysis days. So make sure that you double check when are they supposed to receive their Epigen. Okay. Something else that is a priority when you have a dialysis patient, you need to know, when are they getting dialysis? Okay, when? How do you know when? You can ask the patient. You can call the dialysis nurse. You can look in the orders and see, has the physician ordered dialysis today? If they are just a chronic dialysis patient, then it's generally 3 days a week, and it's a Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, something like that. We usually give them a couple of days to fill up with fluid and elevate their electrolytes, because remember, those 2 days, nothing is coming out, so everything is building up in their body. Okay. If they're getting extra dialysis, it gets a little more complicated, and so you need to communicate with your renal physician and your dialysis nurse when in doubt. If you know they're getting dialysis today, then the one thing that you really want to think about is their blood pressure meds. When someone gets dialysis, their blood pressure is going to drop, because the dialysis nurse is going to pull fluid off, and then they're going to be exchanging and dialyzing their fluid. So the machine on the outside of the body acts just like a kidney. So it runs all the blood through it, it cycles it, and it exchanges everything that needs to be exchanged. And then the dialysis nurse can program the machine for, how much fluid am I going to get rid of? What kind of fluid balance are we looking at? What did the physician order as far as their potassium levels? And that will determine what kind of dialysate, what kind of fluid they're going to put in the machine. Okay, so But as the RN, we know that dialysis will lower the blood pressure. So we want to hold all their blood pressure meds. Very important on dialysis days, you hold the blood pressure meds. Okay? Remember, when in doubt, ask the dialysis nurse for clarification if you think something's going to be dialyzed out. They are your expert resource.